this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
For our first presenter today, we have Bailey Hyland. She is a PGY2 emergency medicine resident at Scripps Mercy Hospital, and she's going to be presenting on post-exposure doxycycline to prevent bacterial sexually transmitted infections.
I wanted to start off with some background on bacterial sexually transmitted infections. So the CDC in 2021 did this surveillance study where they found that of all the patients who were tested for gonorrhea in 2021 at these particular STI clinics that they looked at, about 23% of the men who have sex with men who were tested were positive. And this is compared to only 12% of men who have sex with women only, and only 6% of women. And we see actually a similar trend in the syphilis cases that were recorded in the same year in 2021. So about 31% of the cases of primary and secondary syphilis occurred in men who have sex with men only, compared to only 23% of women and 21% of men who have sex with men. So men who have sex with men are ultimately at a risk of higher rates of bacterial STIs. And a recent systematic review and meta-analysis from 2021 also found that men who have sex with men who are infected with bacterial STIs are actually 2 times more likely to acquire HIV. And next, I just wanted to review some of the potential consequences that can occur with our bacterial STIs, which include epididymitis, conjunctivitis, disseminated gonococcal infection, and then, of course, our neuro, ocular, and otosyphilis. And I'm sure we're all very familiar with the recommended regimens for each of these bacterial STIs, but just in case you need a refresher, we'll typically use the doxycycline 100 milligrams BID for 7 days for chlamydia, ceftriaxone either 500 milligrams or 1,000 milligrams, depending on the patient's weight and assuming no other complications. And then for our early syphilis will be penicillin G-benzathine, 2.4 million units times 1, or times 3 if it's tertiary or late latent. And next, I wanted to introduce you to an important background study that's commonly referred to as the IPERGAY study. This was an open label randomized extension of a trial in France. It included more than 200 men who were having condomless sex with men and who were also using pre-exposure prophylaxis or PrEP for HIV, TDF, and emtricitabine. And in this study, they were randomized 1-to-1 to doxycycline 200 milligrams times 1 within 24 hours after the condomless sex. However, if patients forgot to take it within the 24 hours, they were encouraged to take it up to 72 hours after condomless sex, or they could be randomized to the standard care group. One thing I do want to point out in this study is that doxycycline was supplied as 100 milligram tablets, and the maximum was 6 pills per week or 3 doses per week. So they were restricted in this study to 3 doses per week. Their primary outcome was occurrence of a first bacterial STI, which only included gonorrhea, chlamydia, and syphilis during the 10-month follow-up period. And essentially, they found that the occurrence of a first STI was decreased by about 47% in the doxycycline PEP group compared to the no PEP group. And this was primarily driven by decreases in syphilis and chlamydia. There was no difference in the rates of gonorrhea in this particular study. Next, I wanted to go over the current CDC STI treatment guidelines, which were last published in 2021, and their statement and take on the STI prophylaxis. So they say no long-term data are available regarding the impact of STI PEP on antimicrobial resistance and the microbiome, and that further studies are needed to determine whether STI PEP is an effective and beneficial strategy for STI prevention. And next, I just wanted to do a brief overview of doxycycline, which is one of our tetracycline antibiotics. It binds reversibly to the 30S ribosomal subunit and inhibits protein synthesis, thereby causing a bacteriostatic effect. And then there are no renal or hepatic dose adjustments needed. And then some of the adverse effects that can happen with doxycycline include photosensitivity, teeth discoloration in children under 8 years old, and esophageal injury. And then some of the drug interactions we have to look out for with doxycycline are the chelation DDI, so our di and trivalent cations, which include iron and magnesium. All right, so that brings us to the study in question, which is post-exposure doxycycline to prevent bacterial STIs, otherwise known as the DoxyPEP trial. So this study was published in the New England Journal of Medicine in April of this year. And their objective was to determine the incidence of STIs in high-risk patients taking doxycycline PEP within 72 hours after condomless sex. So pretty similar to our IPERGAY study, which took place in France. However, this study took place in the US, notably Seattle and San Francisco were the two main sites. The funding was provided by the National Institutes of Health, specifically the Institute of Allergy and Infectious Diseases. And then the kits for gonorrhea and chlamydia testing were donated by Cepheid, and then doxycycline was donated by Maine Pharma, but neither company provided financial support for the study. So moving on to our study design, you can see here that there was 2 different cohorts in this study. There were the patients who were taking HIV PrEP, and then there were the patients who were living with HIV. All of the patients were men who have sex with men or transgender women who had a history of STI within the last 12 months. So within each cohort, the patients were randomized 2-to-1. It was an open label trial. So they were randomized to doxycycline hycolate, 200 milligrams times 1 within 72 hours of condomless sex or standard of care. So our primary efficacy endpoint was the incidence of at least 1 bacterial STI each quarter. I want to point out that this is slightly different than the IPERGAY study. So in this study, they did a 12-month follow-up period. So if patients were seen during all quarters and had no loss to follow-up, they would have 4 visits during the follow-up period, and they could have a primary outcome in each of those visits in theory. So it's the total number of visits with an STI over the total number of visits that were completed is the primary outcome here. And then in terms of their primary antimicrobial resistance endpoint, they did look at tetracycline resistance in Neisseria gonorrhoeae and Staph aureus isolated at baseline as compared with the organisms that were isolated during the follow-up period. And then their secondary endpoints included the incidence of each of the component STIs, adverse events based on the Division of AIDS reporting system, as well as patient acceptability. And in terms of inclusion criteria, they included adults older than 18 who were assigned male at birth. They did have to either have a diagnosis of HIV and had to be taking or planning to take HIV PrEP, history of condomless anal or oral sex with a man within the last 12 months, as well as a history of a bacterial STI in the last 12 months. So really, these are very high-risk patients that are being enrolled. And then the exclusion criteria are primarily related to contraindications to tetracycline or doxycycline specifically, including allergies or notable drug-drug interactions, or if the patients were taking doxycycline for some other indication for an extended period, they were also excluded from the study. So next, going on to our statistical analysis, they estimated needing a sample size of 390 patients. They used a significance level of 0.05. The study had 80% power to detect a 50% lower combined incidence of gonorrhea, chlamydia, and early syphilis in each quarter in the DoxyPEP group, and they assumed a 10% annual loss follow-up to come up with their sample size estimation. And they did use a modified intention to treat population. So all the patients were analyzed according to their randomized group, as long as they were enrolled long enough to have at least one of the quarterly follow-up visits. So moving on to our baseline characteristics, we can see that in our HIV PrEP cohort, our patients were a bit younger, around 36, whereas in our persons living with HIV cohort, they were a bit older, around 42, 43. The race of the patients was around 60 to 70% white. there was a higher percentage of Black patients included in the persons living with HIV cohort at around 13%. And then we did have around 30% of patients identifying as Hispanic or Latino in both cohorts. And then in terms of gender identity, primarily the gender identity of patients included was men. However, there were about 4% transgender women who were included. And then in the next line, you'll see that our patients had about 30% of patients who had an STI at baseline. So, during their enrollment and visit, they actually checked them for STIs at that time and treated them as appropriate. But about a third had already had a bacterial STI at that visit. And you can see here the breakdown of each of the included bacterial STIs, primarily gonorrhea, although we do see a lot of chlamydia as well. And around 40% of patients actually had 2 or more STIs in the past 12 months. So even though they were only required to have 1 to be included, some had 2, a pretty high percentage had 2. And then you can see here that our annual income patients were pretty widely distributed across the range that we looked at, with 15 to 30% having less than $20,000 in annual income, and anywhere between 13 and 36% having an income greater than $75,000. So that brings us to our results. We're going to be starting off with the PrEP cohort. So you can see here the primary analysis for any STI that the relative risk for developing an STI was reduced by around 67%. So this is the number, I'm just going to remind you, is the number of quarterly visits with the event out of total number of visits. So the relative risk was 67% reduced to have an event at one of these quarterly visits. And this brings our absolute risk reduction to about 20%. And you can see that in our PrEP cohort, the gonorrhea, chlamydia, and syphilis rates were all statistically significant. So all of these STIs were reduced with this intervention. And they did do some subgroup analyses related to age and how many STIs they had had in the previous month, and the results held in the subgroup analyses in the PrEP cohort. And then moving on to the persons living with HIV cohort, we can see that we also had a reduction of around 62% in the relative risk for any STI. And then it's about an 18% absolute risk reduction between the doxycycline group and the standard of care group. One thing I did want to point out with the persons living with HIV cohort is that syphilis was actually not significant. It was primarily driven by chlamydia and gonorrhea in this particular cohort. And then we also see some differences in this cohort related to age. So our patients who were less than 30 did not meet statistical significance. And then our subgroup of patients who only had 1 STI in the past 12 months also did not meet statistical significance. So next, I wanted to talk about adherence, which is always really important whenever we're considering trials that look at, patients taking medications on their own accord. So in this study, they use these computerized surveys to ask patients, how often are you actually taking the doxycycline within 72 hours of condomless sex? And they found that 86% of patients reported consistently taking their doxycycline, which was defined by a response on the survey as always or often. And then 71% of those patients 71% of the total patients, report never missing DoxyPEP after condomless sex. And then in terms of acceptability, 86% of patients who were in the doxycycline arms reported that taking DoxyPEP was acceptable or very acceptable to them. And moving on to the adverse effects, they use the Division of AIDS table for grading of adverse events. And in case you're not familiar, grade 1 is mild event, whereas grade 5 would indicate death. And they do have one of these charts essentially for each body system. So like cardiovascular system, they would have examples of what would constitute a mild event versus death. So in terms of what they found to be related to doxycycline in this study, they did have one grade 2 lab abnormality, which was transaminitis. And then they had 5 grade 3 events, which included 3 episodes of diarrhea and 2 episodes of headaches or migraines. And they didn't find any serious adverse effects in this trial. And they did have a discontinuation rate of 2%, which was primarily related to either unacceptable adverse events or patient preference. So moving on to the results from antimicrobial resistance, which I think are the most difficult to understand in this study. We're going to start by looking at the Neisseria gonorrhoeae resistance rates. Something I want to start off with is gonorrhea is something that is very difficult to culture. So a lot of the times, we try to culture these organisms and they don't grow out. So that's something to keep in mind here. So we'll start off by looking at this baseline column. So as you can see, the left-hand y-axis, we only had about 15% of the baseline gonorrhea cultures available. This was twofold, like I said, due to difficulty with culturing the organisms. And the other reason was some patients we couldn't get samples from before they were treated. So in that case, they were treated as is the standard of care without getting the swabs. So in this case, we had a total of 15 gonorrhea cultures from the 99 patients who had gonorrhea at baseline. So therefore, 27% of them were resistant to tetracyclines, which was defined by an MIC greater than 2 micrograms per ml. Similarly, after the intervention, we collected swabs from patients who did have gonorrhea. And in this case, we had about 15% available, again, for similar reasons. And we can see that 5 of the 13 that were available were resistant to tetracyclines, which represents 38%. And interestingly, in the standard of care group who didn't receive any doxycycline during the course of the study, they ended up with only 12% resistance, so actually lower than baseline in this case. So just keep in mind when interpreting these results, it is hard to get a representative idea of how many gonorrhea isolates are truly resistant to tetracyclines due to the difficulty with culturing, as well as difficulty obtaining swabs before treating. In addition to looking at the Neisseria gonorrhoeae resistance, they also looked at Staph aureus. I think the primary driver for looking at Staph aureus is because we frequently use doxycycline to treat skin and soft tissue infections, especially in the outpatient setting. We want to make sure that when we're giving doxycycline, for PEP in these patients, are we going to make them unable to use doxycycline if they come in with a skin and soft tissue infection? So I'll start off with the baseline column again. So you can see here we had about 45% of patients who did grow Staph aureus. So in this case, every single patient did get a nasal swab. They were able to do that effectively at the baseline visit, and 45% of them would be considered colonized with Staph aureus. Of this 45% who were colonized, 25 of them had resistance and 190 did not. Resistance in this case was defined by doxycycline MIC being greater than 16 microgram per ml. So this represents a baseline resistance of 12% of Staph aureus being resistant to the doxycycline. And then I subsequently looked at both the doxycycline and standard of care groups at 6 and 12 months. You'll notice that the doxycycline group had lower amounts of Staph aureus isolated, which is likely due to the effects of decolonization after taking doxycycline as part of the study. So we can see that our rate would be 22% at 6 months in the doxycycline group and 16% in month 12 in the doxycycline group, compared with only 10 and 8% respectively in the standard care group. So I think the main thing with interpreting these antimicrobial resistance results is that decolonization really affects your denominator in this case, because you have less patients in the doxycycline group who actually have Staph aureus isolated. So if you were to take the number with resistance divided by the overall number of patients included, you'll find that the resistance rate in doxycycline group was around 5%, compared with only 4% in the standard of care group. So even though these results do seem higher, you do kind of have to take it with somewhat of a grain of salt due to the decontamination effect. So in the end of this study, the authors concluded that the effectiveness data provide evidence for DoxyPEP as an effective STI prevention intervention for men who have sex with men with recent STIs and ongoing condomless sex, regardless of their HIV serostatus. And based on our absolute risk reduction of approximately 20%, you can see that we get a number needed to treat of only about 5. So moving into the strengths and limitations of this study, strengths are that they enrolled an economically, ethnically, and racially diverse patient population. I also think they incorporated relevant stewardship outcomes, and important to all of us here who are practicing in the US, these stewardship outcomes were conducted in the US, which is of course going to most closely mirror our own resistance patterns. And then in terms of limitations, it was an open label trial. So the authors do kind of talk about this in their discussion. They kind of like the open label nature of the trial because they're saying kind of like, oh, we're seeing the net effect of the doxycycline plus any changes in sexual behavior that are due to patients like maybe more actively thinking about their condomless sex encounters. But I think this does take away a little bit from, knowing whether any behavioral differences are contributing to the difference that's seen in the doxycycline group. In addition, they had low enrollment of transgender women at only 4% compared to, greater than 95% of the included patients identified as men who have sex with men. And then there's kind of low generalizability of this study because the patients enrolled were very high risk, patients who have condomless sex encounters, patients who have had STI, in the last 12 months, and 30% of whom had STIs at baseline. And then lastly, this study, at least as far as I can tell, based on my review of the supplement and the paper itself, didn't account for any potential treatment failure. So it's not like after we treated them, we checked to make sure that they actually were treated and cured. So in the event that they did have any treatment failure, they probably would have been recorded in the subsequent quarter as still having the same STI, but it would be counted as an additional endpoint. So that's something to keep in mind as well. I would say it's in line with the standard of practice since we don't typically check for cure with bacterial STIs, but something to keep in mind, especially when you're doing like a quarterly outcome like this. All right, so that brings us to the clinical relevance for all of us. I think, many EDs are either already incorporate or are starting to incorporate like culture and STI callback programs. And I think that DoxyPEP is something that we should consider offering to high-risk men who have sex with men as part of these protocols. Of course, this is a shared decision-making approach. So, getting a good sexual history from your patients, determining, are these actually high risk men who have sex with men or transgender women that should be considered, or, for patients who are lower risk or, different sexual orientations, they might not be supported by this data. So try to avoid generalizing this to those patients. But something we can consider offering to patients who maybe aren't willing to be receptive to like kind of our standard STI prevention, including things like condoms. And then in terms of future directions, I think some further studies are needed to monitor the possibility of emerging gonorrhea resistance to tetracyclines with more widespread use of DoxyPEP. And I think there's kind of 2 trains of thought when it comes to resistance. One is we currently, don't use doxycycline to treat gonorrhea in the US. So in some ways, we're not taking out our primary drug that we use, which is the ceftriaxone. But the other thing is, we saw in the French study that DoxyPEP actually wasn't effective for gonorrhea due to higher rates of resistance. And that's not something that we want to induce by preventing these STIs. So we'll definitely need to continue following this as, DoxyPEP gets rolled out to more patients, in which case the risk of resistance might increase as it expands and is used in more patients as opposed to like an isolated kind of trial situation. All right. And with that, I would like to give a huge thank you to my journal club mentor, Dr. Andrew Smith, who is also my RPD here at Scripps Mercy. And then I also wanted to give a huge thank you to the ACCP PRN EMed Journal Club coordinators, which includes Alyssa and Kaylee, Minden and Tess. I'm sure they put a lot of work in to get these together for you guys, and I know we all really appreciate it. And with that, I'm happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.